plain old Suptain.
Right.
And I'm also happy that he's made such prowess in this world of health informatics and medical informatics. Yet he remains as humble and as approachable as ever. So that's a very heartwarming feeling. His whole journey can be sort of broken up into four phases, as he told me, in an informal conversation that I had with him. And it began right from establishing the need for medical informatics, to then finally going on to curriculum innovation and formalization of the education. And he then went on to integrate this into the digital health landscape, finally leading to a future focus and ongoing application to optimizing use of innovative medical devices in the family medicine and primary care settings. So this is a whole 3-decade course that he has undertaken, right from moving to just being ready for informatics, to development of a safe and ethical workforce for digital India. I hope I've got it right, Satyen.
No, very well explained indeed.
And welcome, welcome, welcome. So, without any further ado, we can begin. So, the floor is all yours, Satyen. Thank you.
Thank you very much, Suchita madam. It's really a pleasure being here. Of course, I have been involved with AHP. I've been a member almost from the beginning, but somehow
Correct.
or other, I've never been actively involved. So hope to be
So,
more
we
active.
decided to make you active.
So today, I'm going to talk about the easy use of digital teaching tools. And this is a picture I thought I'll share. But if you compare this with my current status, I'm not using any of these. I have not put up the green screen. I'm not using a earphone, but these are the ideal setups really when we are supposed to have. And that actually reduces a lot of those distractions which may otherwise come. Of course, now I am taking the liberty of not using any of these because I'm alone in the house, so I'm sure there would be no disturbance. This being evening, I don't think anyone would come either. So but this is, I think, so digital teaching, if anyone is planning, I think this is I wanted to stress upon it that this is really the way it should be. I mean, it should be properly done formally with a proper background without intrusion of anything. Sometimes it can really be very irritating or laughter provoking. In fact, there have been lots of memes because during the COVID-19 pandemic, we had even school children having their school classes from home, and then lots of issues arose. So what are we going to look at today? And of course, as I said, I mean, I'm not going to uh, talk too much of theory, but I'll give hands-on exercise. Actually, I had initially thought of giving multiple group exercise, but then breakout rooms are a problem. So we'll stick to one exercise only. So uh, I hope that at the end of this session, you'll be having the idea that how can you develop the digital competencies. That means how can you proficiently navigate and use these tools, apps, and platforms on a day-to-day basis. Also, we'll try to uh, bridge a bit of theory and practice together. And I think many of the things which I'm going to talk about, many of you are already using. So it would be a refresher course for you. But what I'm trying to say is, if we make a proper plan, exactly how to do it, what are the tools, when to use, then we'll have a better coherent idea. So first few minutes, I'll be talking about what are the different types of online teaching and learning tools. And as I said, most of you are using many of them. Then I'll go into a bit of a comparative analysis of which one to use and when. More importantly, how do you choose a suitable method for that particular class? Then initially I had thought of 2 group activities in 2 breakout rooms, but now we'll settle to one. And then, of course, that I think we'll give about 45 minutes for the group activity. And then for the last 15 minutes, we'll have some debriefing, overview, question, answer if anyone has. If I want to summarize the whole talk in one slide, so the main easy to use digital tools, of course, learning management systems, I think all of you are familiar with Google Classroom, Moodle, Canva, and so on. But interactive quizzing and gamification, I think many of you are now using many of these Kahoot quizzes, Mentimeter. For virtual communication, even this one is through Zoom. Apart from this, we have Microsoft Teams and Google Meet, which are the most widely used platforms for synchronous lectures, small group discussions, virtual clinical training. Then for content creation, sharing, YouTube, like this is being streamed live in YouTube, and it would be available for anyone to have a look later also whenever they want it. So it's a just-in-time service. Then there are podcasts also on particular topics. And now many of you also use this interactive whiteboards and worksheets, Padlet or live worksheets and so on. So how do we really go ahead? Because this, as I said, is more of practice rather than theory. So for implementation, the simple thing is, of course, start simple. Begin with the familiar tools, whether it's video conferencing, shared drives, before going into the complex simulations. Now, the second part is very, very important because now many of us are hardly using laptop or desktop. We are doing everything with a smartphone. So you have to ensure that whatever you are doing, it is mobile friendly. You must use tools that work well on smartphones because they may be accessing the resources on the go while moving, while traveling. So mobile friendliness is very, very important. And pedagogy, andragogy, heutagogy, all those things, obviously, each are important. So technology must fit the learning objective rather than whatever is available, I'll use for all purposes. So what are the different types of online teaching learning tools? Learning management system, I think many of you have been using Moodle or Google Classroom or Canvas. Then there are the visual simulation platforms like SimX. For conferencing, we talked about Zoom, MS Teams, Google Meet. All these support interactive remote learning. And this can be used for enhancing the clinical reasoning through virtual patients. Then we have programs for this interactive quizzes, and Mentimeter is now used in many of the conferences also. And collaborative platforms for the Slack or Padlet, these are commonly used. So what does a learning management system do? It is actually a central hub for organizing the course materials. You can host the assignments, you can track progress. All this, the whole course can be put up through this LMS very easily. Then virtual simulation and clinical tools. These are platforms which offer virtual patients, 3D animated models, simulation scenarios. So we have augmented reality, virtual reality, mixed reality, different types of hands-on simulations where you can practice without hurting anyone. Now, video conferencing, it's a two-way video conferencing. Two-way interactive video conferencing is meant for synchronous learning, whereas many of the tools are available for asynchronous learning. A learning management system is essentially asynchronous. That is something you have to always keep in mind. Synchronous requires the teacher and the learner to be present at the same time. In asynchronous, they can have a look at the materials, the resources, whether it's video or audio or text, whenever they feel time. So both are important and they serve different purposes. Then we talked about the interactive engagement tools, quizzes, and so on, surveys. Then for content creation and collaboration, now you have got lots of programs. Canva is used very widely for the infographics. Padlet, Edupuzzle, these are used. And social media communications, so Slack and private Facebook groups, that's a community of learning. When you have a community of practice, community of learning, so whether it's an email group or a private Facebook group or WhatsApp group, they can be used for various community activities, peer support, maybe informal clinical decision as well. If we look at the methodologies, flipped classroom is the most widely known one, where videos, podcasts, and books are used for pre-class study, and that is the asynchronous part. In the synchronous part, live sessions, we can have problem-based learning, simulation-based learning, and so on. Teleeducation is wherever video platforms are being used for remote teaching or remote patient consultation. And when we combine these, then it will support a blended approach, moving beyond passive learning and consumption to active, clinical focused, and competency-based education. For virtual patient, CIMEX is a professional grade VR medical simulation, and it's high fidelity immersive training. UBSIM is a VR platform focused specifically on simulation, allowing for realistic clinical scenarios. Then VR patients, that's a physiologically based VR simulation tool, first responders and healthcare providers. PCS Spark is an AI-driven virtual patient encounters, good for health discipline learners. Then there's Virtual Pulse BCIT, that's a web-based platform for managing high-risk, low-frequency clinical scenarios. Just some of the examples, there are many more. Now we come to the comparative analysis part. Now, online teaching utilizes various tools that can simulate the clinical environments, manage complex curriculum, foster collaborative learning. So we can look at it through the pedagogical classification. So first is the simulation and immersive technology. So online medical simulation, various platforms are there. We can use virtual patients like this Oxford Medical Simulation. Extended reality is where we are going for virtual reality, augmented reality, mixed reality, all put together. So you can have for surgical training, anatomy training. Then we have 3D anatomy platforms also, biodigital, human, and so on. So these are the simulations or immersive technology. This is one of those when I was trying a few years back. And I think many of you are using these sorts of things regularly. And students do enjoy it. And it is safe both for the patient because you're not hurting anyone, safe for the doctor also, because when you're operating on a real patient with some infection and there's an accidental prick, then the surgeon is also at risk, but here no one is at risk. The next group of tools is the LMS, and I think Moodle has been the most popular, though now the use is quite reduced. Blackboard was even there before Moodle. Canvas is a later one, but more or less a contemporary. They have been used. Google Classroom, again, although it's more easily available, it's integrated with the Google Suite, but it's, again, not used as much as it could have been, but it's there. And I think many of the colleges, may not be medical colleges, but many of the engineering colleges do use it quite regularly. Then what are the collaborative and communication tools for real-time interaction? We come back to Zoom and Teams and Meet again and again because those three are the ones which are being used the most. We can do collaborative document editing. Google Docs or Microsoft 365 allows students to co-create clinical case reports, research projects. Multiple people can edit simultaneously. Then you can have virtual communities of practice through Slack, Discord, WhatsApp, and so on. Interactive and gamified learning. So there are various tools which gamify the learning thing, Kahoot and quizzes. These are good ones. Then visual curation. So Canva or PictoChart can develop excellent infographics. And many of the large language model AI programs available also giving those. Then interactive whiteboards, Miro, Google, Jamboard. These help in collaborative brainstorming of diagnostic pathways. Then we have some content repositories. FOAM is free open access medical education. So there are lots of blogs, podcasts, and then you can get lots of excellent materials on YouTube, Twitter, or X. Then there are specialized repositories like MedEd Portal for peer-reviewed health education tools and HEAL for digital health study materials. For podcasting, there are platforms like Spotify or SoundCloud. So you can have the medical specific podcast for just-in-time learning. That means you can learn at the time you really want to learn. Now we come to how to choose a suitable one. So before choosing a suitable one, you have to be very clear about certain things. Exactly what is the specific learning objective of that particular session? That lesson plan is important. Then you have to find out the target audience, what's their background knowledge in the domain, in the technology, and then, of course, the instructional setting. So once you are clear about all these three, then you can start choosing. So the first thing to decide whether you want asynchronous, like LMS, pre-recorded podcasts, or synchronous, this live simulation breakout groups. So where do you use the asynchronous tools? For lower order cognitive tasks, remembering and understanding facts at a self-determined pace. And synchronous or live tools are necessary for higher order tasks like applying knowledge in clinical context, analyzing complex cases, negotiating group discussions. Then you have to also consider the concreteness of the experience. So if you are looking at the abstract learning, the theory or the principles, then text-based LMS modules or 2D diagrams are sufficient. But if you want some more concrete learning, like clinical skills, then you can use those extended reality high fidelity simulations. That is when you can do learning by doing, repeating any number of times you want. Of course, before you go ahead with it, you have to evaluate the technical and institutional readiness. That means what is the bandwidth and access of the place from where you are doing. Do you have the setup for immersive technologies, for virtual reality or augmented reality, high-speed internet, specific hardware like headsets? So if you don't have that, then you may have to look at low bandwidth resources, downloadable podcasts, and so on. Then the ease of use, that means effort expectancy. So which are easy to use compared to some where it's more complicated, the use of that particular tool. And then privacy and compliance. So whether it's a DPDP Act compliant or GDPR in Europe or HIPAA in USA, you have to be very careful about protecting the patient data, especially for the clinical scenarios. So can you have a checklist for selecting which tool? So first point in your checklist should be alignment. Does it directly support the module's objectives? The second point in the checklist is interaction. Does it foster active learning or only consumption? Third is analytics. That means, does it provide feedback to the instructor on the progress? Fourth is sustainability. Does the institution have the budget and IT support to maintain it in long term? And fifth point in the checklist is peer influence. So you have to check which are being used mostly by your peers. And that often, of course, favors one over the other. So now you can use any of the multiple large language model AI programs like ChatGPT available. And you can actually do like this. You can make your sample selection table. So if you want to teach anatomy or surgical steps, then you can choose a virtual reality or 3D anatomy platforms so that you can get an essential 3D spatial visualization. If you want to practice clinical decision making, then virtual patient simulations are great, allows for risk-free diagnostic practice and feedback. If you want to do a full semester course, then some learning management system like Canvas or Moodle, because it will have everything in that. It will centralize the grading, materials, communication, everything. You can have discussion groups and so on. If you want to boost engagement during the lectures, then gamification like Kahoot. These encourages participation and instant assessment. If you want to support remote, busy professionals, and I think this sort of a lecture is more of that sort. So micro learning or podcasts are the best method because you can get a flexibility and it will fix in your clinical schedules. Another way, if you look at it, so we have to look at the interactivity. That means how much is it engaging the learners, whether it's simulation or quizzes. Then accessibility. Does it work on low bandwidth? Is it mobile friendly? You have a mobile version of Moodle like that. Then content quality. Of course, it must be medically accurate and locally relevant. Then assessment. Can it track progress and provide analytics? So for that, you have this quizzes or Socrative. These are good tools for assessment. Integration, if you want to make it compatible with your existing LMS, whether it's a Moodle or Canvas. So H5P or Microsoft Teams, they can do a bit of integration. Or like I said, Google Classroom is integrated with Google Suite. Security, does it protect the patient data? Does it comply with the regulations? So tools with end-to-end encryption must be used. So if you want to do a quick decision matrix, so here they're comparing three, of which Moodle and Google Classroom are free, but Labster is paid. If you look at the ease of use, Moodle is moderately easy to use. It's not really very easy, but compared to Moodle, both Google Classroom and Labster are very easy to use. Interactivity, Moodle has got extremely high interactivity because it can support so many plugins. You can add many programs to it. Google Classroom is moderate, but Labster is quite high. If you look at offline access, for Moodle, there's partial offline access also. So Moodle, that is a great advantage. So even if you're not connected to the internet, you can definitely access some of the things in Moodle, which you can't do with Google Classroom or Labster. So compliance is, of course, high in all the three. Now, this is one exercise you can try whenever you get time. This, how many of you are aware of this yup.ai? If you have used it, you know it very well. If not, you can try it right now. So yup.ai, that is YUPP, yup.ai. Here, if you put, so here I put a question, how to choose an optimum digital tool for teaching, learning, and health professional education. So it immediately brings in responses from two of the LLMs. So in this particular case, when I put this question, I got an answer from OpenAI O4 Mini, the Pro version, and from Devstral Medium. So these are the two LLMs from which I got this response. The full screen, the whole response is not there in one screen, but this is just the opening part. And you can see, you can compare, you can also ask it to get it from which LLMs you want, or you can go and say, give me more, and you can go on getting. So this is a very good starting point, and you can get an idea. When you look at the two responses, they're quite different. I mean, the basic content may be similar, but the way they are presented, they're different. And you can think which way you want to go. So this is a very good starting point. So now we come into the group activity part. And this is where I think you're all familiar with it. The roles and responsibilities, you can have a leader and moderator, a recorder or a pusher, a timekeeper and presenter. Essentially, your job would be to reconcile, not just forming, but brainstorming, then norming into the design goal so that you can perform. You have to be certain that you are looking at 6 or looking at duck or rabbit, 6 or 9 duck or rabbit. The way you look at it could be different, but you have to come to the same conclusion. Anyone, either 6 or 9, or either duck or rabbit. You cannot have both. So the group activity that I've thought and will practice over the next 45 minutes or so. So we can have till 8:15 for the uh, activity. And so here, because we don't have too much of a flexibility, in a breakout room, we could have done even better. But here, so what I would suggest, and I think Dr. Jyotsna or whoever else can help me. So objective is you have to assess the institutional constraints. The activity is you form groups among yourselves. Think of different groups. So one is the owner of the hospital. It could be a government hospital, then the government officials, or the private owners, the promoter or administrators. Then you can have another group. A few of you can play the role of faculty members, teachers and researchers. Then another few can take the role of the IT personnel, the technology personnel. A few others can represent the finance officials. And I would definitely like to have also a student representative. So although none of you are students, but you can represent students. You interact with students daily, so you know what they really want. So the activity, what is the activity that you have to draft an institutional policy to integrate digital tools for daily teaching activities by 2027. So if we break down into the tasks, what you have to do, you have to negotiate the priorities. Budget versus faculty training versus technology infrastructure. You have to resolve some of the conflicts, whether you go for proprietary tools from vendors or do you get free tools. And you can finally have a consensus policy, a one-page draft. So is this activity doable here, Dr. Jyotsna?
Jyotsna?
I'm here. I'm here. Yeah.
How
How do
many
we go
people are
about it?
there right now? How many people are there right now?
17, totally 19,
20.
but
Yeah.
I think around, yeah.
And the two of us, yeah.
Yeah, let me stop sharing for the time being. So we are having about say 5 groups, so maybe 4 in each. So can it be divided like that?
You want the breakout rooms then?
If there's no breakout room, you can stay in the same room, but you can discuss among yourselves. So actually, if you are known to each other, you already have your phone numbers, you can interact in WhatsApp. That's the simplest way, quickest way also. So if all of you know each other,
No,
maybe
I don't think it's not a, it's, I don't think it's a homogeneous group, sir.
okay. In
Yeah.
that case, you can just you can discuss here. We can all think aloud. So will that
Yeah.
be possible?
So I'll just try to put them into 2 rooms.
If you're just giving 2 rooms, maybe then we can look at one is a finance group, the other is a teacher and researcher groups. Maybe finance and technology we can put together. So one group will discuss the budget constraints and the technological infrastructure. And the other is, of course, you can say teachers and students together in one group. So what do they need? What
Yeah.
would be most convenient for them? And biggest problem is, of course, the technology and budget. So the 2 groups can decide among themselves and then decide they have to come to
Yes,
a
so
common
we have
ground.
got 2 rooms. So what do you want room 1 to work on, sir? Finance and?
Yeah. So finance and technological support, finance and tech support. And second room is teachers and students.
Okay.
So the academic part, academic versus budget and technology.
Can we have the breakout room for 20 minutes, sir? Maybe 45 might be a bit too long for the group.
Yeah. They can do the discussions in 20 and come back and then they can present in the main group.
Yes.
In fact, they may have to interact between themselves to come to the consensus. So the 2 groups will also have to interact. So they have
Okay.
to come and interact here only.
Yeah.
So
So since
first
we
they
have the,
decide among themselves what are their constraints, how much they can allow the others to take, and then there has to be a face-to-face.
yeah. So it will be lovely since we have a small group today. It will be really lovely if we all can get to discuss on this in a very interactive manner. Okay, so I'll be opening up both the rooms now.
Yeah, so it would be about 9 to 10 people in each group. 9 or
Yeah,
10.
we have about 6 to 7 in each room, sir.
Okay, 6 to 7, fine. That should be good. That's good for discussion.
Tell me, Jyotsna, then when this goes on the YouTube, will the rooms be visible or will everything be blank?
I'll have to check now, ma'am. What
No,
is
then
the...
do you want to just continue on this one big large group because then other people can benefit when they
That is true.
what?
So if you stay here, I think what you can do, you can first divide into the 2 groups and let's have the 2 leaders first because leaders are
Okay,
important. So if you can have the 2 leaders, then they can choose their teams and they can discuss here itself instead of in the
and then
breakout.
they can come back and discuss.
Yeah,
Okay,
because ultimately all have to discuss together. Then only we'll get the policy document. Because it will be not 2 policies from 2 groups. It will be one policy only, which will be a consensus of both the groups.
I think almost all have joined except for a couple of them. Yeah. Sir, do you want to join any of the groups and facilitate the discussion there?
So have you put them in the breakout groups?
Yes, they are already in the breakout rooms.
Yeah, so I can go into both one after the other. So let me.
So I'll do one thing. I'll make you co-host so you can move
Yeah,
about.
yeah.
Yeah. Okay. Just give me a minute. I'll make you co-host. Huh. Well, I think you should be able to move about, sir.
Right. Yeah. So first, let me get into the teachers and students room. So there are 6 people there.
Yes. Yeah, all our participants have come back, Dr. Supten. So over to you for initiating the discussion now. And we have had some new entrants also join in.
Yeah. So now I think it's the two groups have to put together. So the teachers, students group, you can put the policy in front of the technology and finance group, and then let them decide what you are saying. Is it feasible financially and technologically? And based on their inputs, we'll have the final recommendations, final policy guidelines. So you can, one of you from the teachers learners group can present it. After listening to you, the finance and technology team will respond. Please go ahead.
Swapnil sir, shall I share and can you present, sir?
Present, I think. You can present.
Yes. Yes, sir. So, sir, can I just go up, start? Yes, can I just give you an overview of this is what we discussed in our breakout room regarding the expectations from teachers and students, followed by institutional expectations regarding the implementation, adaptation, and implementation of digital tools on a daily basis for the academic year 2026 and 27. And this was we deliberately kept AI out of discussion because that's another domain to be discussed. So here, the teacher aspects will be they expect user-friendly systems or user-friendly tools both for managing and management of tools and delivering the tools or interacting should be easy. And for teachers, onboarding training as well as periodic refresher trainings about the tools has to be there because that in many colleges the teacher population is dynamic. Many people leave, transfer, and the new comers are there, and the tools are also dynamic. They get updated frequently, and some kind of connectivity issues are there in some colleges or many colleges. So especially when we go for small group arrangements and all. So the interactivity wise, either connectivity arrangements or some kind of connectivity allowance for the this is what was discussed from us. If we are asked to connect to the students asynchronously, apart from the classroom, which is synchronous teaching, after the classroom, if we are allowed to, if they expect us to connect, and apart from teachers also expect students should be trained about ethical use of digital tools and digital decorum to maintain digital etiquette. So sometimes when we share the screen and ask them to connect and give them open-ended questions, some students might come up with some kind of rubbish on the platforms and all. Like, so we have to teach them about maintaining digital decorum as well. And regarding the students' expectations, it has to be easily accessible, especially with their smaller devices like mobile phones or tablets, whichever they have. Connectivity arrangements for them inside the lecture hall. Some lecture halls are have a huge capacity of 250 students when there might be network issues. And students expect feedback in real time from the teachers. So in a large group setting, it's a little bit difficult. And faculties, they expect faculties to respond to their queries at the end of each interaction. Whatever questions are asked, maybe out of 250 students or 200 students, 50 or 60 might be having different kinds of queries. So their expectation is their queries has to be answered then and there, and that is their expectation using that digital tools. And some students might prefer anonymous interactions. They don't want their name to be displayed in front of everyone. They are a little bit wary about their questions. They do not know where they stand, whether they are asking a rubbish question or a silly question or something kind of. So they want an anonymous interactions. Few tools permit anonymous interactions. For institution, it's all about a cost should be as less as possible. The benefit and the effectiveness should be as more maximum as possible, and for that will aid the implementation or adaptation by the institution. And there should not be any implementation issues, and results has to be at least from the student feedback or from the performance of students, it should be positive. And one more thing, which is the institutions expect is data privacy. So whatever goes inside the digital tools and comes out should be within their grasp or reach or within their limits. With all these aspects, we tried preparing. We took the aid of ChatGPT to we fed these aspects and asked it to come up with a policy framework for adaptation and adoption and implementation of digital platform for undergraduate medical curriculum. So this was the purpose. The purpose is to establish a structured institutional framework, and objective is to enhance daily classroom interaction, facilitate feedback, delivering and managing regulatory complaints, data privacy, scalable, cost-effective digital ecosystem. And it has given us the a typical policy kind of document, including the rationale for adaptation, governance. So what it suggested is this is a major important part is governance. So it suggests to form a digital education governance committee in the institution. So this will have following people starting from the dean of a medical college to IT director, manager, senior faculties and student faculties. So this committee will oversee the adoption and implementation. So they will approve the platform selection, oversee the implementation, monitor the complaints, and ensure regulatory alignment and review security. So as faculties, we are supposed to use the platform, provide timely responses, maintain professional conduct, and attend onboarding and refresher trainings. For students, the roles have been given: avoid misuse, adhere to digital etiquette, provide constructive feedback. For the IT team, for the academic committee, and all these things are given. The framework decides upon different criteria to come up: functional criteria, compliance criteria, cost criteria, and accessibility criteria. So based on four criteria, these criteria came up from our own inputs, which came out of our breakout room discussion. And so first phase is planning to implement, which is from April, May, and June, 3 months, piloting in some department. And July to August we'll pilot and we'll collect the feedback. Full rollout will start from September. And from October to March is where we audit whatever we got and we optimize it. So onboarding, refresher training, support mechanisms, and I think that's pretty much it about including the financial aspects, monitoring, evaluation, quality assurance. Everything has been mentioned. I know that this is from AI and we have to sit together. The committee should be formed and the committee will sit together and come up with the final framework for adoption and implementation of this digital framework. Thank you, sir.
Yeah, I think this is a very good comprehensive document. So now let's listen to the finance and technology team. What you have thought and what is your comment on this document? Any particular areas you'd like to see in greater details or you'd like to refute? The second team, please go ahead.
Manjusha, would you like to chip in?
It's quite a comprehensive policy they have already given. So my job has made very easier. I just wanted to add uh, core objectives from my side that must have already been included in their document, but I still want to talk as a financial this thing. As a vision and principle, core objective should be improve clinical learning and decision making skills, support educators with teaching automation and analytics, promote safe, ethical use of AI in training and patient simulation, and ensure equitable access across departments and learners. Now, ethical foundation that should respect the privacy and confidentiality, bias mitigation, transparency in AI recommendations, and accountability for AI assisted decisions. Now, financial policy should cover the infrastructure, software licensing, data and storage, training and capacity building, maintenance and support, and evaluation and compliance. And I think these points have been explained elaborately in this thing, his policy. Now, funding sources are internal budget allocation, government grants, research funding, public-private partnership, alumni and philanthropy. Then cost management strategies is open source AI tools wherever possible, shared platforms across the departments, usage-based licensing, cloud leasing versus buying hardware. Now, technological policy adaptation and governance should include system must comply with the HIPPA or local data privacy laws, ISO or IEC standards for educational technology, interoperability with existing LMS on EHR. AI validation and approval is must, and there should be a technical review board, pilot testing, and performance monitoring. Now, data security and privacy uh, there should be encrypted storage and secure data flows, which is role based across access control, regular vulnerability scans, and incident response plan, consent protocols for learners and patient data. And then curriculum integration is must, that should enhance, not replace, core pedagogy. Case-based simulation using AI tutors, virtual patient and personalized feedback, natural language tools for clinical reasoning, data science modules integrated with curriculum. Now, vendor and procurement policy are to be selected with the due diligence, and contract terms can be used for that. Implementation roadmap is phase one is assessment, two is planning, third is pilot testing, four is scale up, and fifth is evaluation. Capacity building and training includes faculty workshop for AI literacy, mandatory training for students on digital ethics, certification in health AI tools, and dedicated e-learning resource center. Evaluation metrics include learner outcomes improvement, time saved in admin and teaching tasks, accuracy in AI mediated simulations, user satisfaction of students as well as faculty, and return on interest and cost efficiency. Risk and compliance checklist is ethical review board sign off, bias assessment in AI models, privacy compliance audits, and regular impact reporting. Examples of tool are like AI tutors and assistants, where you can use ChatGPT style clinical reasoning apps, simulation platforms where you can use virtual patient simulators. So smart assessment includes automated grading analytics. Adaptive learning is personalized style study recommendations. Data analytics, you can use curriculum performance dashboard. Now, I think there is more. There is one more thing is a sample policy statement. All AI system used in education must be transparent in function and explainable to the users. In data governance, learner and patient data shall be stored and processed only with the consent within secure and compliant database. Ethical use, AI shall support, not replace clinical judgment. Human oversight is mandatory. And there should be a formal written policy document and budget template should be provided with that. But I think as one of the curriculum committee member from my college, where I've made some documents for skill lab and all, this particular type of policy making, and the funding is tremendous. You will need at least 20 to 30 crores for digitalization, AI tools, as well as faculty training, integration with the IT, infrastructure development, if you have to align with the infrastructure, and there will be some cost for audit, budget for the audit, and for the evaluation. And that's all from my side.
Yeah, I think you have also summed up well. One of the things which I think, I mean, now AI is basically an integral part. So all the digital tools we are talking of are both using AI as well as AI enabled. The other thing, which is HIPAA, is a US law. So in India, we have the DPDP Act, Digital Personal Data Protection Act of 2023, and the Digital Personal Data Protection rules were notified in November 2025. So they are very much applicable. It's very important. What you said, the cost about 20 to 30 crores. So if you actually, it depends on exactly what you are going for. Now, if you're going for the augmented reality, virtual reality, mixed reality, extended reality, all those things, the cost may go many times up. So simulation labs, I think you would be aware, in various medical colleges, government or private, different colleges have different levels of simulation labs. The National Medical Commission mandate is there for to have something. So the bare minimum maybe everyone has, but there are various medical colleges, both in the government sector as well as private sector, who are actually having very high-ended things, and where for the budget probably you have to go on adding a few more zeros at whatever amount you say. So budgeting itself is, of course, a very, very difficult task, and that requires a lot of time and effort. But overall, I think both the teams have worked very hard. And the other thing which I must confess, even if you use AI tools, the large language models like ChatGPT, the amount of time allotted for this exercise is not sufficient. I mean, it will require more hours, and in fact, you have to think and rethink, sleep over it. Then maybe next day you'll have some better ideas, clearer ideas, and that's how a lot of refinement is required, and that has to be done. But I think,
Can
as I
I
said,
request the previous person, Dr. Parthsati, to share his document on the group of AHP?
I in WhatsApp, ma'am. I
Yeah,
was trying.
sure.
Just a minute. I can share in the just a minute. I'll
Or
share
you
it
can share the link here in the
the
chat
chat
if you
box.
want.
I'll just
Yeah.
share in the chat box. Yes.
yeah, that is I mean, a good start, but that would actually require a lot of refinement, multiple iterations for getting it into a practical policy. And ultimately, of course, it's the institutional authorities who have to vet it, because it depends. I mean, the way you have put it, the basic principles may remain the same, but especially for budgetary allocation, technological upgrades, it will vary from institute to institute. You just cannot have any one size fits all. And some of the private medical colleges who may have a lot of money and they're spending just to show, just to use it as an advertisement so that more people get admitted, more students get admitted. But that is just for show purpose. So that does not necessarily mean that it is being used optimally. I mean, I personally have been involved with one such medical college, and I have seen the way it is done. It's not the right way. But then those who are spending money, they think differently. So those things, a lot of negotiations are required. The sort of governance committee that was formed is very pertinent, and maybe a few more members can be co-opted in that committee. So that way, I think you have really done a great job. So any of the other group members would like to add anything on either of the groups, whatever they presented? Anything to ask the other group? Anyone?
Sir, can I just
Yes, please go ahead.
Dr. Patsati, go ahead, please.
Yeah, I think we
yes.
lost him.
Sorry. Ma'am,
Go ahead. Go ahead.
sir, yes, sir. Regarding finance and infrastructure, I was just about to, my opinion, I just wanted to cast this thing, sir. So there should be digital tools are supposed to make the learning into an even playground, sir. So there should not be the digital divide between colleges or between universities or between students. So I fear that with the advent of digital technology and with the amount of money involved in it, it might even create a divide and it might broaden a divide in some aspects. So that shouldn't happen with the sense of digital thing. And so whatever implementation is going to be done for the classroom sakes, I think the universities have to implement these networks on a broader level, which covers all the colleges. So that will be a better idea to make it a level playground for all the students in our medical education, sir.
Yeah, some of the things which you said, maybe at one point of time, the National Medical Commission will include in their policies that would be applicable to each and every medical college. But there would always be differences. I mean, that's why which are the so-called centers of excellence will remain centers of excellence, but basic minimum would be there. And now the digital divide is actually going away. In fact, if you look at the rural places, remote places in India, actually the connectivity is quite good. And this COVID-19 pandemic really proved to us that actually a lot can be done sitting at home. This COVID-19 pandemic acted as the chief transformation officer, or the CTO. And the two of the sectors which were affected the most are healthcare and education. And you are dealing with healthcare education. So definitely If we don't make the best use of this digital solutions now available, I think that would be a disservice to our students. The other thing which I wanted to say about this group activity, I mean, and I think although we didn't have too many members, but whoever were there were quite actively participating. So essentially, if we have such a group activity, this sort of a group activity builds an empathy for systemic challenges and collaborative problem solving. So when we say collaborative, that is within the departments of the same institute or university, but also, as you rightly said, across the different universities, across the different states. So we definitely need to have more and more. And I think AHP is, again, a great platform for that. Like we have that MEU India, that particular Google group, which Dr. Sanjay Bedi had started many years back. It's still quite functional, and often we get lots of useful and recent information, which otherwise we may not have the time to look for ourselves. So this is also a very important thing. And before I wind up, I would like to I think Dr. Padmini wants to say something. You have raised your hand. Please go ahead. Dr. Padmini, you want to say something? Your hand is raised.
I think it must have been by mistake, sir. Please go ahead.
Okay.
Hello.
Chandrasekhar, yeah, please go
Sir,
ahead.
sir, when you are telling COVID infection and all, no, sir. In that COVID infection, I'm in the government college, sir, Carvan Medical Government College, sir. They're given us for this telemedicine, sir. So in this COVID only use this telemedicine, and the patients use this telemedicine right and left, sir. Like 24 hours to use this telemedicine in the for COVID. But for the patient, it was very useful. For the students, the question marks are now.
No, there are definitely, I mean, limitations are there. There's no doubt about it. But as you rightly said, yes, during the COVID-19 pandemic, only that time the erstwhile Medical Council of India, that Board of Governors, they brought out the Telemedicine Practice Guidelines 2020, TPG 2020. And even now there are lots of issues. The Indian Medical Association doesn't like it. And there have been multiple court cases which are not favorable. But telemedicine is something which is here to stay because the technology has reached that level. Now we are even having robotic telesurgery, and it has already been done. I mean, the robots are working in one particular location on the patient. The surgeon is thousands of kilometers away from another city operating that robot. So that is a reality in India. That is happening and happening well. So those things, technology is advancing and we need to adapt to it. And that brings me back to my favorite question whenever I give any activity like this. At the end of my session, I always ask everyone. So some of you, if you are brave enough to share, have you unlearned anything in this 1.5 hours? Something you thought you knew like that, but now you know it's different. What you thought was not right.
Sir, all this digital and all, no, sir. All this digital and all, no, sir. We noted it, sir. All the updated the digital things we are written in the book, sir. Then we'll be finding all this AI and all in that what you told this that website we're not knowing only, no, sir.
No, I'm not asking about new learning or relearning. I'm asking unlearning. Something you knew as this, but at the end of this hour or so, you suddenly find what you knew was not right. It is not this, it is that. Has anyone had any sort of unlearning? In fact, I was actually pleasantly surprised in the last workshop that I did last week in IMS BHU. At least 5 people gave different points, the different concepts that they unlearned during that session. So I was really quite taken aback. Usually, maybe 1 or 2, someone say, but there are more than 5, they said, and all were legitimate. So any unlearning any of you had here? I think Dr. Swapnil has raised the
I
hand.
had some problem with the unmuting. I just got unmuted just now.
Yeah.
No, I
go ahead.
just wanted to share that we can maybe collaborate with the IITs and other institutes regarding digital education and not try to manage everything ourselves.
Right.
So, especially in Tamil Nadu, the IIT Madras very cooperative about all. I mean, they try to help in this kind of thing. So maybe
Yeah.
that can be done.
Definitely. This is the age of cooperation and collaboration. So definitely all helps are welcome from everyone. And at different places. Whoever is available and whoever can help definitely can go ahead. I think there was another hand raised. You have, who was
Yes,
that?
sir.
Yeah,
Yes,
please go
sir.
ahead.
So the one thing I unlearned is that, of course, I know that interactivity helps, but more interactivity helps more. That is what something I learned rather than unlearned. Means the AHP webinars are tailored very nicely, where there is debriefing and discussion at the end. But now, if we have these breakout room sessions right in the middle, we leave them with the AHP webinars with more confidence regarding the particular subject.
Yeah, I think thank you for that. In fact, and I must congratulate Dr. Jyotsna because in the morning also she was not very confident about the breakout rooms. So that's why I reduced that exercise. I had more exercises in mind. But yes, now this is a good way of doing. And there are multiple ways of doing. There are shortcuts because actually now most of the classes, I'm a visiting faculty at multiple institutes, and most of the classes I take are online. 90% classes are online. Only less than 10% maybe I take face-to-face classes. Mostly for a conference or exam, I have to travel. Now the travel is also reduced. But definitely, the more you interact, in fact, that's what I said in that was a face-to-face conference. That was AI in healthcare, and now almost every day, everywhere, there's an AI in healthcare conference. Even day before yesterday, I came back from Jaipur from another conference. But AI in healthcare or digital health, whatever it is, that's not the point. The point is, if we learn together as a group activities, this collaborative learning, peer-to-peer learning, that is really very effective. And once we do it hands-on, it stays. I mean, what you did, I could have actually have got that output. Say, this is how a policy document will look, and I could have showed in the PowerPoint, but that would not have registered. When you are yourself trying to think, trying to find out what is it, the way you definitely remember more. And I think Confucius is often attributed to this. I mean, when I hear, I forget. When I see, I remember. When I do, I know. So doing this group activity is essentially doing. And we are trying to find out the problems, how to overcome the problems, how to solve them together. And we definitely need a lot more, I mean, multidisciplinary and interdisciplinary interactions. So the so-called the vertical integration, horizontal integration, those have been for the clinical areas, but then even for teaching learning, I think that's very important. And whether we accept or not, the students are now much more tech savvy than we can think. In fact, many of the students now they graduate even without touching the printed textbook. So that is a reality. In fact, many of the things, concepts you'll see, you can see excellent animated videos on the YouTube. And if you look at that animation, giving a simple example, muscle contraction, we had to read 10 times or more, even then we didn't understand what is muscle contraction, how is the actin myosin complex working. But once you see the animation just once, a lot of things become clear. And that applies to so many concepts. And now medical knowledge, believe it or not, is doubling every 60 days or so. Within 2 months, the medical knowledge is doubling. So it is humanly impossible for anyone to remain up to date. This is something it can hurt our ego badly, but it's a reality. When the medical knowledge is doubling in less than 2 months, how can one keep abreast? So we have to take help of all sorts of AI tools and everything, whatever is available. And we have to use them to filter out, I mean, what we need. We don't need this information explosion. So that brings us to health data literacy. We need to know what is required, what is important. And so digital literacy and I mean, health data literacy together is digital health literacy. So digital health literacy is again something I had given a lecture at JIPMAR about 5 years back. That's there. The whole lecture is there in YouTube. But these things are very important, and I think these should be, I mean, your etiquette and other things are part of it, but exactly what to learn, which data to look at, which information is useful, what knowledge would be really useful. That is something we can't do on our own anymore. We have to rely on technology.
Sir,
Yes, you want to
I
say something? Yeah, go
want
ahead.
to add one point that now the NCERT syllabus is so much in depth that I teach physiology, and most of the physiology concepts they are knowing. Only the molecular stuff and the clinical stuff which needs to be applied needs to be taught really, and that can be taught more better by these flipped classroom approaches and all these things, and more engagement.
Anyone else would like to add anything? If not, over to Dr. Jyotsna or Dr. Sucheta for the.
Thank you so much for this very, very interactive session. And yes, as you rightly said, whatever we do, we have to use with caution. And there's a lot of learning. I was very pleasantly surprised with Manjusha's take on on her analysis, because in the beginning, our group was very wary about talking or about chipping in. And you should see the way everyone just, she just took off. So, yes, with effort and with the right kind of mind set up, I think we can achieve what we set to do. So, with that, over to Jyotsna. And thank you so much, Subtain. It's been fun.
Thank you. It was a very small group, but very interactive, and I could see the brains buzzing up, and the way the participants have come together and shared their knowledge and expertise over here is really nice. Thank you so much, Supten sir, for taking them through this session. So, and it's been a good dialogue, and we look forward to the next one next month. So we'll be announcing it shortly there. So in case if any of your colleagues would like to watch this video again, please catch it on the AHPE live streams account. And until then, good night, everyone.